So in this lectorial we're going to talk about some of the pathology related to the urothelium. Remember, the urothelium is that specialized lining which extends all the way from the urethra through the bladder up the ureters and into the renal pelvis, and so it's the major epithelium of the urinary tract. So the urothelium, of course, is a specialized squamous epithelium, and its most important characteristic is those umbrella cells which sit up on the surface. These are cells which have the ability to slide one over the other, a bit like those belts on the luggage rack things at airports. And it's this ability to slide which means that the urothelium is able to be protective whether the bladder is in a state of distension, such as the picture there on the right, or not. So all that really changes throughout the urinary tract is the thickness of the layer underneath the urothelium. So obviously in the bladder you're going to have a very thick muscle layer which we call the detrusor, whereas in the ureter that muscle layer isn't quite as well developed, and when you're up into the renal pelvis, the muscle layer is quite thin. So up in the renal pelvis we can see that there is this direct relationship between the renal parenchymal tissue and the renal medulla, delivering urine right into that urothelial lined renal pelvis. The most common condition actually involving the urothelium doesn't come to pathologists but more to microbiologists. This is the common urinary tract infection. So inflammation of the urothelium most commonly occurs as an ascending infection by some of the common organisms such as E. coli and the like that you will learn about ad nauseum when you do the microbiology section of your course. We're more concerned here about infection which not only involves the urethra and bladder but actually ascends up the urinary tract and can involve the renal pelvis and secondarily the kidney, and so this forms the condition of bacterial pyelonephritis. So this is an example of a kidney which has been involved by acute pyelonephritis, probably caused by an ascending infection in someone predisposed, perhaps with comorbidities, or showing vesico-ureteric reflux, or perhaps some form of obstruction in the urinary flow, perhaps because of, say, a large benign prostate gland. So the kidney is swollen and we've got all these little yellow areas you can see on the cortical surface, which are areas of microabscess formation. We should distinguish sort of the acute pyelonephritis from this other important condition, chronic pyelonephritis. Here the kidneys are small and shrunken and scarred, and if we look at the cut surface here we can see there's areas of sort of depression often overlying the renal pyramids, where the cortex has been lost and replaced by this scar tissue. So down the microscope this is what it looks like. You can see in the center there at the top the cortex where the glomeruli are is very thin indeed. There's some sclerotic glomeruli, so the glomeruli have been replaced by these little hyaline dots, and you can see all the purple areas in the background which are inflammatory cells. So there's been this intense regional loss of renal parenchyma in these conditions. So what causes this chronic pyelonephritis? It's largely a combination of infection and an increase in urinary tract pressure, and usually these are both long-standing conditions, so repeated infection and persistent increase in urinary tract pressure. One of the most common causes for the development of this condition of chronic pyelonephritis is vesico-ureteric reflux. So normally, of course, urine flows down the ureters and is stored in the bladder. And with micturition, the rise in pressure in the bladder, you don't want urine to be refluxing back up into the ureters. And so normally the ureters implant into the bladder wall in this oblique way. And so when the bladder fills up, the bladder wall acts as a kind of a sphincter or valve. But in some people, there's a congenital condition where the ureters are implanted not on an angle, and so the bladder wall doesn't act as a sphincter, and so every time there is voiding, then urine also refluxes back up into the kidney. So this increased pressure and its association with infection can lead to chronic injury to the kidney, chronic pyelonephritis. So this is an important condition to recognise because this is a silent condition, and these children who are refluxes will present later in life with chronic pyelonephritis, so they will have hypertension and chronic renal failure, unrecognisable until later in life. And it's important to recognise because this is surgically correctable, and so it's important to really actively investigate children who have urinary tract infections to exclude this vesico-ureteric reflux, because we don't want them to develop chronic pyelonephritis, because when they do, they may require dialysis or renal transplantation. We should make mention of urinary tract stones which form in areas of the urothelium. The most common of these places for these stones to form is up in the renal pelvis. You can see that there on the right. On the left is a larger bladder stone which is formed de novo in the bladder. Where do these renal stones come from? They come from precipitation of supersaturated chemicals in the urine. You can see from the diagram oxalate is the most common of these supersaturated elements, which combines with calcium to form oxalate stones. Uric acid stones occur but are less common. So what happens is these chemicals become supersaturated in the urine, usually because of increased excretion by the kidney, combined with sort of low urine volumes or changes in the pH. So they then form a crystal nucleus on which further crystals can grow and aggregate. These crystals become sort of stuck on or interact with the epithelial cells and get held in place, and so the process proceeds over time, and these stones then form. Why are we interested in these stones? Well, they can migrate, for instance, from the renal pelvis down the ureter and be associated with a lot of morbidity in the form of renal colic. They predispose to infection. They often irritate the urothelium and produce alarming hematuria. They can cause scarring and stenosis, particularly of things like the ureter, and they can even cause perforation and escape of urine or a urinary fistula. The axial CT that you can see there is of a large urine collection which is formed around the ureter of a patient who's had a chronic stone which has caused the ureter to perforate and form this urinoma. And stones obviously can cause urinary tract outflow, which can lead to acute kidney injury or chronic renal failure. Now we should come on and talk about urothelial carcinoma, which is the malignancy of urothelium. In the past this used to be called transitional cell carcinoma, TCC, so you'll still see some reference to that term, but we should really be using the term urothelial carcinoma now. So this is a very common cancer, 9th in the world and the 4th most common in males in our country. It's more a malignancy of developed countries and more common in patients over the age of 60. So it can occur in any site of urothelium. The bladder is the most common, but we can see it in the urethra, in the ureters, and up in the renal pelvis. Because the urothelium is affected in a wide area, so-called a field effect, these tumours often occur at multiple sites, or after treatment of one tumour, then they can recur at other sites as well. So they can be a real ongoing management issue. So the picture there on the left shows a radical cystectomy which has been opened. It shows at least 3 different urothelial cancers in the bladder. On the right at the top is kidney. The renal pelvis has been opened to show a urothelial carcinoma there in the renal pelvis. And below that we've got a kidney and ureter. The ureter has been opened to show this obstructing mass in the lower part of the ureter. And again, this is a urothelial carcinoma. These tumours are strongly associated with various environmental factors, the major one of which is tobacco smoking. So this is the major established risk, and at least half of all bladder cancers have direct attribution towards cigarette smoking. So the kidney, of course, metabolizes breakdown products from cigarette smoking, excretes these in the urine, and so the urothelium has a period of time where it's exposed to these chemicals and is easily damaged. We recognise sort of 2 major pathways, or 2 major types of urothelial carcinoma. The first one is a sort of low-grade cancer which is often very superficial and forms a sort of papillary exophytic mass, and these only tend to develop high-grade changes late and invade late or relatively uncommonly. The second type of pattern is the high-grade route, where these tumours don't tend to develop out of a superficial papillary component but out of flat carcinoma in situ, and show a very high propensity to invasion and metastasis. So this is the cystoscopic appearance of the typical pattern 1, or the low-grade tumours. This represents the vast majority of newly diagnosed bladder cancers. So these are usually non-invasive or only very early invasive, and they often have this rather papillary exophytic appearance. They're usually cytologically low grade, but the trouble is that once they're removed, they tend to recur locally because of that field effect, and so these patients often require multiple repeated resections. Microscopically, this is what they look like. These papillary exophytic lesions. They're formed by mildly thickened urothelium which has some mild cytologic atypia. Over time they can develop some high-grade changes, and they can invade, usually only superficially. So the yellow arrow there shows one of these tumours invading into the lamina propria. Again, you can see this at high power on the right hand side there. But again, this would only be a T1 tumour. So the second pattern are these nastier tumours, which tend to arise not from the papillary superficial lesions but from carcinoma in situ. So these are usually high-grade tumours, p53 mutated, and so they're often flat or ulcerated. And not only do they invade the lamina propria, but they invade muscle tissue and adipose tissue. So you can see on the image there islands of tumour infiltrating between bundles of detrusor muscle. So in the muscularis layer, these tumours have good access to lymphatic spaces, and so it's usually not till bladder tumours invade into the muscle layer that they develop metastatic potential. So this is what this urothelial carcinoma in situ looks like. It's a flat, full thickness dysplasia, rather than that surface papillary from the other pattern. And you can see in the other image there the beginnings of invasion developing out of this urothelial carcinoma in situ. Most patients with urothelial carcinoma, the initial presenting symptom is hematuria. There might be microscopic hematuria or macroscopic hematuria recognized by the patient, and the urine will be different degree of discoloration depending on the amount of red blood cells. So if there's a large amount of red blood cells, the urine often has this tea-like appearance that you can see in the tubes on the left. Diagnosis can be easy because it's easy to get the patient to pee into a container, and we can examine the urine cytologically and recognize malignant cells from urothelial carcinoma in urine quite quickly and cheaply. These days there are a number of molecular tests available that look for not cytologic features but the molecular events, and so the patient pees into a container, the urine gets sent off to a molecular lab, and you can make the diagnosis this way, although these tests cost $400 or $500, whereas a urine test ends up costing $20. So these nasty urothelial carcinomas, the invasive urothelial carcinomas, usually require radical cystectomy for treatment. We can see the image on the left here is of a radical cystectomy. We've got a large sort of polypoid tumour which was invading into the muscle, and the arrows there mark this sort of flat erythematous area, which is the extensive area of associated urothelial carcinoma in situ. So these patients require something to happen to their urine, and so normally what will happen is a loop of ileum is isolated, and you can see that happening top on the right, and the ureters are implanted into this, and this loop of ileum is brought out onto the abdominal wall, and you can put a bag onto it, or it's cannulated to form what's called an ileal conduit. That's the end of this presentation. Over time we've done reasonable